Hello and welcome back to my channel. And this is a continuation of a series of goal 5000 MCQs, and this is the part B of the endocrinology SBAs MCQs and as well as recalls. And let's continue with our question number 13. The question number 13 is female reproductive system, the oocyte. These are the true and false, and let's see some more things regarding the oocytes, and basically these are the oogonia which fills the ovary during the fetal life. And these primordial germ cells, they divide by the mitosis. First there is a mitosis, and until shortly before the birth. At birth, the female, they has she got the female baby, she has got 1 million oocytes, and these 1 million oocytes, they are formed after the mitosis of the cells. And then the next step, that after the birth of the baby, the primary oocytes, they are contained in the ovary of the fetus, and here they are arrested in their first meiotic division stage, or in the prophase stage of the first meiosis. This is very important because this is the first meiosis, or the first prophase stage of the meiosis, where they are arrested and they are surrounded by the granulosa cells, and oocytes, they are surrounded by this protective layer. It is no this whole set is known as the primordial follicles. These primordial follicles, they are present in the cortex. This is the cortex, this is the medulla, the cortex of the ovary, and here there are the 10 million or sorry 1 million oocytes. And what happened next, that when there is a luteinizing hormone, when it acts over the cortex of the ovary, the dominant follicle, it completes the first meiotic. Here in this, at this stage, the first meiotic division is completed. At this stage, the first meiotic division is completed, and it is converted into secondary oocyte, and the first polar body is formed in the ovum and contained half the chromosomes. The second meiotic division, it does not complete it until the fertilization. When the sperm will fertilize this ovum, then the second meiotic division will get completed. Now let us see our options. Option A, the primary oocyte, they are arrested in the first mitotic division. This is false because it is first meiotic division. And then the next option, the completion of the first meiotic division, they occurs in response to the luteinizing hormone. Yes, that is true. And first polar body is found in the sperm head. No, it is found with the ovum. So this is false. Option D, the completion of the first meiotic division, they leads to the secondary oocyte. Yes, this option is true. And the second meiotic division is not completed until after the fertilization. The option here is implantation. So this is false. It is the true answer is the fertilization. Okay, now let's move question number 14. That is about the follicle stimulating hormone. And the follicle stimulating hormone, we all know that it is the follicle stimulating hormone. It is a glycoprotein hormone which is produced by the anterior pituitary. And FSH, it has a molecular weight of around 30,000, and it is comprised of 204 amino acids. And FSH, it is similar composition with the anterior pituitary gland hormones, which are also has got the thyroid stimulating hormone, the luteinizing hormone, and they all have almost the beta HCG. They have almost they have the same subunits, like they are the alpha subunits and they are the beta subunits. The FSH, it acts on the ovaries and testes to promote the gametogenesis. The major role of the FSH, it is in the gametogenesis, and it is also has a hormone of in the formation of the hormone synthesis. FSH, it is raised in the women with the which are in the menopausal when they have achieved the menopause, and this is because there is a reduction in the estradiol. When there is a reduction in the estradiol, the FSH will increase. Let's move to our option, and it is produced by the posterior pituitary gland. No, it is the option A is false because it is produced in the anterior pituitary gland, and it has a molecular weight of the 28,000 kDa. No, it has, yes, it has around the weight of the 28 1000 to 30,000. And it has an alpha and gamma subunits. No, that it has alpha and beta subunits. And it is raised in the post-menopausal woman. Yes, that is true. And it is a glycoprotein. Yes, again, this option is true. Now, the next question is regarding the luteinizing hormone. And we all know that the FSH and LH, they are both produced by the anterior pituitary glands, and they are glycoprotein in nature. And like thyroid stimulating hormone, they have the subunits of the alpha subunit and beta subunit. And both FSH and LH, they are released in response of the gonadotrophin releasing hormone from the hypothalamus. And FSH, it stimulates the receptors of the granulosa cells of the female ovarian follicles. And these granulosa cells, they will produce the estrogens. And there will be increase when there is increased level of the estrogen, when there are the increased level of the estrogen, then there will be a negative feedback on the hypothalamus, and which lead to the decrease in the FSH production. Raised level of the estrogens from the growing ovarian follicle, they lead to the increased pulses of the GnRH and subsequent surge of the LH, and which in turn lead to the ovulation at around day 14 of the menstrual cycle. FSH levels, they are raised after the menopause. We have discussed it, because when there is a decreased level of the estradiol or the estrogen, these lead to the ovarian atresia. And this works by a positive feedback loop, thus increasing the FSH level in an attempt to stimulate the estrogen production. Let's move our option. Luteinizing hormone has alpha subunit identical to that of the thyroid stimulating hormone. Yes, that is true. Not only thyroid stimulating hormone, but also the beta HCG and as well as FSH. And they maintains the corpus luteum. Yes, their main function is to maintain the corpus luteum. And they reaches its peaks at day 21. No, they reaches at their peak at the day 14, and thus this option is false. It is a steroid hormone. No, it is a glycoprotein hormone, and it is released in response to the gonadotrophin releasing hormone. Yes, that is true, because FSH, LH, and they are released by the gonadotrophin releasing hormone from the hypothalamus. Now, next question is regarding the pubertal changes in the female. And pubertal changes, they are very important. In UK, the average age of the puberty is 12 years, and before the age of 10 years, this is considered at the precocious puberty. And it describes, at the 12 years of the age, it describes a series of changes in the endocrine functions and the physical appearance which accompany the changes to adulthood. In female, thelarchy, it is the development of the breast. And this development of the breast, it is preceded by the adrenarche. And this adrenarche, it is the process of the pubic hair development, and which is thus followed by the menarche, which is the commencement of the menstruation. The menarche prior to the age of 10 years, it is considered as a precocious, and failure to commence by the age of the 16, it warrants a further investigation. The Tanner staging, it is a mean of the grading pubertal breast and pubic hair development in the females, and it is also used in the males to grade the pubic hair and testicular development. The Tanner staging, it is 1 to 4, and 4 is the stage of the adulthood. And puberty, it is associated with the commencement of the gonadotrophin releasing hormones. And these gonadotrophin releasing hormones, they pulse in the late childhood, which become increasingly regular and gradually changes from the nocturnal pulses to the pulses occurring every 90 minutes in the late childhood. And these pulses, they stimulate the production of the follicle stimulating hormone as well as the luteinizing hormone, with the subsequent production of the estrogen and testosterone. And growth hormone, they are levels, they also increases during the puberty, and it is mediated by the insulin like growth factor, and thought to be responsible for the pubertal growth spurt. So let's move to our options. Option number A is thelarchy preceded menarche. Yes, it is the TAM. So this option is true. And then adrenarche precedes thelarchy. No, that option is false, because thelarchy is preceded adrenarche, and it preceded the menarche. Tanner staging is a mean to grade the pubertal development. Yes, that is true. And menarche before the age of the 12 years is considered to be precocious puberty. No, that is option is false. And changes occurs in response to the increasing regular pulses of gonadotropin hormone. Yes, that is true, because initially they are irregular, and in the late childhood they become regular and occurs after every 90 minutes. Now let's move towards the next question in regard to the menopause. And menopause is very important and most asked question. It is very important. You have to take time to understand it. Now the first thing is that the menopause, it is a retrospective diagnosis. It is usually made when a woman they had been amenorrheic for at least 1 year, and the climacteric encompasses the time from when a woman they may experience the classic menopausal symptoms like hot flushes, and together with the menstrual irregularities up to the cessation of the periods. With age, there is an ovarian atresia with fewer ovulatory cycles, and these lead to the low levels of the estrogen production. And these low levels of the estrogen production, they are going to stimulate the follicular stimulating hormone and luteinizing hormone levels. They are then going to increase in order to compensate the decreased estrogen levels. Associated with the reduction in overall the levels of the estradiol, it is the failure, there will be the failure of the endometrial proliferation and subsequent cessation of the menstrual. The measuring FSH, it leads to be a very useful investigation. The levels more than 30 international units per liter, they are considered to be diagnostic for the menopause. And the measurement of the estradiol levels is not very useful tool, because there are the other compensatory function which lead to the conversion of the androstenedione to the estrogen by the ovarian tissue, adipose tissue, the liver and adrenal glands. Estrone is a predominant form of the estrogen postmenopausally, and there is no role for the measurement of the LH, estrogen, testosterone, or the progesterone level. These are the hormones of the menopause. FSH in the menopause, the FSH is raised. Luteinizing hormones, they will also raise. Estrogen, overall the level of the estradiol they decreases, but estrogen they still are made peripherally while the conversion in the tissues. And estrone they predominate is the predominant postmenopausal estrogen, and testosterone they will remain unchanged, and progesterone they are also going to increase. Now let's see our option number A, that the average age of the menopause in UK is 51 years. Yes, that is true. And estradiol levels, they can be used to a diagnosis of the climacteric or the menopause. No, that option is false, because these are the FSH levels. And FSH hormone and luteinizing hormone they rises. Yes, it do rises. And progesterone level they rises. No, they decreases. And urogenital atrophy is caused by the falling levels of the estrogen. Yes, that is true. Now let's see next question, and it is regarding the hormonal replacement therapy. Again, this question is important, because hormonal replacement therapy, it aims in the reduction of the symptoms of the menopause, and they also reduce the osteoporosis. The symptoms of the menopause, the most common is are the hot flushes. And HRT, they can be administered either topically, orally, or there would be the available in the forms of the implants and the transdermal patches. And the main consequence of all the form of the HRT is the estrogen. And in order to prevent the endometrial hyperplasia because of unopposed estrogen levels, all women who have the uterus, they should also receive the HRT in the form of the progesterone. And alternatively, another source of the progesterone they can be administered. These are the levonorgestrel intrauterine system. And in women who have had a hysterectomy, and estrogen only HRT is suitable, because they don't have the chances of endometrial hyperplasia. And synthetic progesterones, they are structurally different from the progesterone, but they have the similar activity. Testosterone, they can improve the libido in the postmenopausal woman. The side effects of the HRT, they include the breast tenderness, the bloating, as well as headache, nausea, depression, and subjective reports of the weight gain. Tibolone, It is a synthetic steroid drug that is classified as a hormonal replacement therapy. It is a chemical inert substance until it is absorbed, when in it then becomes active. Now let's see your options. Option A, HRT, they should contain the both estrogen and progesterone. No, that is not necessary that they both have the estrogen and progesterone. And progesterone, they can prevent the endometrial hyperplasia. Yes, that is true. And side effects includes the breast tenderness and the blotting. And the blotting, yes, that's it's again true. And testosterone, they has no role in the HRT falls, because testosterone, they can improve the libido. And tibulone is an artificial form of the estradiol. It is basically a synthetic steroid drug, and it is chemically inert substance, but when it is absorbed then it become active. So it is yes, that option, according to me, it should be true, but here it is false. Let's see why it is false here. Okay, now let's move our next question, that is question number 19, and it is about the prolactin. Prolactin, it is basically a peptide hormone, and it contains 198 amino acids and has a molecular weight around 24,000 daltons. And it is a single peptide chain and is a somatotrophic hormone, and being stored in the somatotroph cells of the anterior pituitary gland. And it has a similar structure of the growth hormone and the placental lactogen, and it is secreted by the anterior pituitary gland, and its secretion is responsible for the lactogenesis and the development of the breast tissue. Prolactin level, they raises in pregnancy and during lactation. So let's move to our options. The options are, it is a peptide hormone. Yes, that is true. Basically all the hormones which are present in the anterior pituitary gland, they are the peptide hormone or glycoprotein hormones. They have a molecular weight of the 44,000. No, we just discussed that it is 24,000 daltons, and it is produced by the anterior pituitary gland. Yes, that is true. It is produced in the anterior pituitary gland, and production increases in response to the dopamine release. That is false, because when there is a dopamine increase, they will decrease. And it has a similar structure to the growth hormone. Yes, that is again true, because it has similar structure to the growth hormone as well as the placental lactogen. Now let's move. Next question. It is that the prolactin secretion, it is stimulated by, okay, again prolactin, and then prolactin secretion is stimulated by a serotonin as well as thyrotropin releasing hormone. The main inhibitor of the prolactin secretion is dopamine, and dopamine antagonist including the metoclopramide, the domperidone, and diazepam, and the haloperidol, and the phenothiazide such as the chloropromazine. Therefore, this stimulates the productions of the prolactin, because they are the dopamine antagonist. And prolactin, they inhibits the pulsatile release of the gonadotropin releasing hormone and estrogen. Stress, they can also cause the release of the prolactin, and therefore a non-stressful vein puncture technique is required when measuring the serum prolactin level is in the diagnosis of the hyperprolactinemia. Other stimulants of the prolactin secretions includes exercise as well as sleep. Now let's move our options. That metalloclopramide administration, yes, it do secretes the prolactin, and thyrotropin releasing hormone, yes, again, and chlorpromazine administration, yes, that is again true, and haloperidol, yes, that is again true, and also the vein puncture which lead to the stress, they can cause the stimulation of the prolactin secretion, yes, that is again true. Next question is regarding the oxytocin, and oxytocin, it is produced by the supraoptic and paraventricular nuclei of the anterior hypothalamus, and it is then transported to the posterior pituitary gland, where it is stored and released. It is known peptide, and which consists of the 9 amino acids, and it has a very similar structures to the vasopressin, which is antidiuretic hormone. Another nona peptide which is also stored in the posterior pituitary gland. Oxytocin is involved in the release of the breast milk, and rather than its production, it is involved in the let down reflex, whereby the stimulation of the nipples by the suckling of the infant, they lead to the release of the oxytocin, which then lead to the milk ejection. Prolactin is responsible for the milk production, and oxytocin, they also plays an important role in the contractions of the uterine muscle during the labor. So let's move to our options. Option number A is it is stored in the hypothalamus. That is false, because it is stored in the posterior pituitary, and it acts by a G protein couple receptors. Yes, and it is a nanopeptide. Yes, that is again true. It is responsible for the milk production. No, prolactin is responsible for milk production. This is for milk release. It has an identical structure to the vasopressin. Yes, not identical structure, but a very similar structure to that. Now let's move towards the next question, and it is this question is regarding the human placental lactogen. And the human placental lactogen, it is again a polypeptide hormone, and it is produced by the syncytiotropoblast of the placenta, and it consists of 190 amino acids, and it has two or disulfide bound, and it has a similar structure to both prolactin and growth hormone, and it is diabetogenic, and such that it is anti-insulin, and it is thought to modify the mother's metabolism in order to supply the nutrients to the growing fetus. And levels of the human placental lactogen, it increases throughout pregnancy, although interestingly human chorionic gonadotropin is sometimes undetectable in normal pregnancy. Let's see our options. The human placental lactogen, it is secreted by the syncytiotropoblast. Yes, it is true, and it has a similar structure to the prolactin. Yes, again this is true, and it is secreted by the corpus luteum. No, it is secreted by syncytiotropoblast, and it is a diabetogenic. Yes, that is true. It consists of the 190 amino acid. Yes, again this is true. Now the next question is the human chorionic gonadotropin, and the human chorionic gonadotropin, we commonly call it as HCG or beta HCG. It is a peptide hormone and consists of the 244 amino acids. It has alpha subunits which is similar to the follicle stimulating hormone, the luteinizing hormone, and thyroid stimulating hormone, and a beta subunit, and it has a peak in the concentration level during the second trimester and usually reduces in the third trimester. In the gestational trophoblast disease, a fertilized ovum, they forms the abnormal trophoblastic tissue which secretes a large amount of the HCG or beta HCG. HCG is usually given during the assisted conception regimes. Let's see our options. It is a glycoprotein. It is a peptide hormone, not glycoprotein, so the option is false. And it can be used in the fertility treatment to induce ovulation. Yes, that is true. And it is seen at the suboptimal levels in the gestation trophoblastic disease. No, they are very high in the GTD diseases, and they raises throughout the pregnancy to reach the peak levels at the term. That is again false. The peak levels is during the second trimester, and the third trimester they started decreasing. It is produced by the corpus luteum prior to the blastocyst implantation. That is again false, because it is produced by um, um, uh, the trophoblastic tissue. Okay. Now let's move our next question. It is again regarding the human chorionic gonadotropin, and we know that it is secreted. It is secreted by the syncytiotropoblast, and the responsibility of this hormone is to maintain the corpus luteum and stimulate it to produce the progesterone. And the levels of the HCG, they increases throughout the first trimester, and they reaches as a peak at around 12 weeks of the gestation. And although HCG is detectable throughout the pregnancy, HCG, they may be given to stimulate the ovulation in the woman with the subfertility, and its action, due to its structural similarity to the luteinizing hormone, the serum HCG levels, they are massively elevated in the gestation trophoblastic disease. And in addition to the HCG levels, they are raised in the germ cells, tumors, and the, for example, of the testes, as well as other form of the cancer such as the pancreatic and adenomas. Let's see our options. They may be secreted in the males with the testicular cancer. Yes, that is true. And they can be secreted by the pituitary gland. Yes, that is again true. and they consist of the alpha and gamma subunits, that is, because they have the alpha and the beta subunits, and they helps to maintain the corpus luteum in early pregnancy. Yes, that is true. And they consist of the 244 amino acids. Yes, we have discussed this previously. This option is true. The next question is regarding the hypothalamus synthesis. Hypothalamus, the hormones which are secreted or synthesized from the hypothalamus, they are the gonadotrophin releasing hormone, which stimulates the luteinizing hormone and FSH. They also secretes the growth hormone, growth hormone releasing hormone, which stimulates the growth hormone release from the anterior pituitary gland. Then the corticotrophin releasing hormone, it secretes or stimulates adrenocorticotrophin hormone release, and then somatostatins, and then thyrotrophin releasing hormone, which stimulates the thyroid stimulating hormone, and it releases prolactin, FSH, TSH, and from the anterior pituitary gland. Now let's see our options. Option A is the synthesis the thyrotrophin releasing hormone. Yes, that is true. The prolactin, no, that is false. That is false. And then the oxytocin, yes, that is true. Then follicular stimulating hormone, that is false. And thyroid stimulating hormone, that is false. The prolactin, follicular stimulating hormone, thyroid stimulating hormone, they are from the anterior pituitary gland, not the hypothalamus. Now the next question is regarding the anterior pituitary gland. And the anterior pituitary gland, it is also known as the adenohypophysis because it sits in the sella turcica. The pea-sized pituitary gland, this sits immediately below the hypothalamus, and to which it connected to why the pituitary stalk. And the optic chiasma, this sits directly in the front of the anterior pituitary gland, and the anterior pituitary gland, this secretes the following: the thyroid stimulating hormone, adrenocorticotrophin hormone, prolactin, growth hormone, melanocyte stimulating hormone, and the gonadotrophin, follicle stimulating hormone, and the luteinizing hormone. Let's see our options. That the anterior pituitary gland produces vasopressin, no, it is from the posterior pituitary gland. And thyroid stimulating hormone, yes, that is true. Somatostatin, that is released from the hypothalamus, so that option is false. And oxytocin is again from the posterior pituitary gland, prolactin from the anterior pituitary gland, yes, that is. The next question is regarding the posterior pituitary gland. And posterior pituitary gland, it is sits in the depression at the base of the sphenoid bone, which is called the sella turcica. It is comprised of the two anatomical and functional distinct parts, the anterior and posterior, and each are responsible for the storage and secretions of the various hormones. The posterior pituitary gland, also known as the neurohypophysis, the anterior was adenohypophysis and the posterior is neurohypophysis. It is not a true gland, but rather an extension of the axonal projections of the supraoptic and paraventricular nuclei of the hypothalamus. The anterior lobe of the pituitary gland is derived from the embryonic ectoderm, and the posterior pituitary gland is not a gland, and it is not even a site of the hormone synthesis, but it stores the oxytocin and vasopressin, both synthesized by the hypothalamus. And these nona peptide hormones are stored in the granules in the axons terminals, ready to release for the hypophyseal circulation. Now let's see our option. Option A, it stores the oxytocin. Yes, that is true. And release the nonapeptide hormone into the hypophyseal circulation. Yes, that is true. And it consists partially of the axonal projection from the hypothalamus. Yes, that is again true. And it is a site of the vasopressin production. No, it is only a site for the storage. And it is also known as the adenohypophysis. No, it is known as the neurohypophysis. Now let's move towards the next question. It is regarding the pregnancy. And prolactin levels, they rises during the pregnancy, and the maternal iodine levels, they falls due to combined effect. Like prolactin, it is going to increase during the pregnancy, and the maternal iodine levels, they fall due to the combined effect of the increased urinary excretion and the fetal demand. And relaxin, they has a variety of the sources. In males, it is produced by the prostate present in the semen. In females, relaxin is produced by the corpus luteum and the breast, and in pregnancy by the placenta. placenta, and it may have a role in the ligament relaxation during the pregnancy and the cervical dilatation. Relaxing the levels, they rises during the first trimester of the pregnancy, then falls at the end of the trimester, only to peak again close to the delivery. The follicle stimulating hormone, the levels, they fall in the pregnancy, and thyroid stimulating hormone, they rises during the pregnancy, and this may be partially due to the thyrotrophic properties of the human chorionic gonadotrophins. Now let's see our options. Option number A, prolactin levels increases, yes, that is true, and the maternal iodine levels falls, yes, that is again true. Relaxin, the levels, they peak in the second trimester, no. The relaxin levels, they rises in the first trimester, and then close to the delivery, so this option is false. And follicle stimulating hormones, they rises, no, they decreases, and thyroid stimulating hormones, they increases, yes, that is true. Now let's move to our next question. It is the adrenal functions during the pregnancy, and adrenal functions, they usually increases during the pregnancy, and it is due to the corticotrophin releasing factors and or the hormones. The synthesis of both the cortisol and cortisol binding globulin, they both increases during the pregnancy. Levels of aldosterone, angiotensin 2, and renin, aldosterone, angiotensin, and renin, they also increases, and the trophoblast increases the amount of the ACTH production, with overall maternal levels, they remain stable. Let's move our options. Option number A is that the cortisol levels, they decreases throughout the pregnancy, that is false, because all levels, they increases during the pregnancy, and then cortisol binding globulin synthesis increases, yes, that is true. And aldosterone levels, they fall, no, they increases, and angiotensin 2 level fall, no, they also increases, and renin level, they are the unchanged, no, that is also false, because aldosterone, angiotensin, and renin, they all increases during the pregnancy. Now next question regarding the calcium hemostasis in pregnancy. Calcium hemostasis is markedly changed during the pregnancy because of the changes in the maternal physiology and the need of the meat fetal demand. The serum albumin concentration, albumin, they decreases during the pregnancy, and because of the dilutional effects of the volume expansion, and lead to a reduction in the levels of the albumin bound calcium. If the levels of albumin decreases, then albumin bound calcium is also going to decrease. Unbound calcium, they remains the same, and to meet the fetal calcium demands, there is an increased production of the parathyroid hormone, and a subsequent increase into the 125 dihydro cholecalciferol, and fetal plasma levels of the calciums, they are higher than that of the mother, reflecting active transport across the pregnancy or across the placenta. And move to our options regarding the fetal plasma levels of the calcium mirror that of the mother, no, that is false, because the fetal calcium levels, they are going to increase. Plasma calcium concentrations, they are unchanged by the pregnancy. Yes, that is true, because the serum calcium levels, they will remain same. Albumin levels are going to decrease in pregnancy. Overall albumin, it decreases because there is a heme dilutational effect, so that is option is true. And then the parathyroid hormones, secretion is increased, yes, that is again true. And then 125 dihydrocholecalciferol production is unaltered, no, that because they are going to increase. Now the next question. Let's move to our next question, and this question is regarding the thyroid functions during the pregnancy. And overall, thyroid functions is they remain unchanged during the pregnancy. However, there are some notable changes. The synthesis of the thyroid binding globulin by the liver is increased, and total T3 and T4, they're also going to increase as the result of the rise of the thyroid glands stimulation hormones, and the levels of the free T4, they do fall in the second trimester. In the second trimester, the level of T4, they are going to fall, and and in the second and the third trimester, and the thyroid stimulating levels, they shows some fluctuation in the first trimester with the increasing level. In the first trimester, they are going to increase, and with the increased level of the human chorionic gonadotrophin, and leading to the fall in the overall TSH levels due to the HCG thyrotrophic activity. During pregnancy, the thyroid gland increases its uptake of the iodine, and the iodine is going to be increased, not in overall pregnancy, but the uptake of the thyroid gland increases. Now let's move to our options. Option number 1 is the synthesis of the thyroid globulin gland is increases. Yes, that option is true. And the total T3 and T4, they are decreased. No, the false, they are going to increase. And the levels of the thyroid stimulating hormones are unchanged during the first trimester. Yeah, that is again false, because of the beta HCG, these levels are also going to increase. Emesis gravitarum, they may be caused by the fluctuations of the level of the T4 fluctuation. Yes, that is true. And the free T4 levels start to fall in the first trimester. Yes, they are going to start to fall in the, yes, they do start to fall in the first trimester, and they have fallen in the second and third trimester. So this option is correct. Now let's move to the next question, and that is regarding the growth hormone. Growth hormone, it is a peptide. It is a peptide hormone, and it has 191 amino acids, and the locus for the growth hormone gene is on the chromosome number 17. Chromosome number 17. It has a molecular weight of around 21,000 daltons, and is structurally similar to that of the prolactin and the human placental lactogen. And it is secreted from the anterior pituitary gland, and from the somatotrophs in response to the GHR, growth hormone releasing hormone from the hypothalamus. And somatostatin is a direct inhibitor of the growth hormone. And growth hormone, they releases stimulates the synthesis of the insulin like growth factor, and it stimulates the lipolysis and the glyconeogenesis. Let's move our options. Option number 1 is it is secreted by the hypothalamus. That is false, because it is secreted by the anterior pituitary gland, and it is a diabetogenic in action. Yes, that is true, because it is going to release the act on the insulin growth like factors. It has a molecular weight of 21,500. Yes, that is true, because it has the molecular weight of 21,000 daltons. And option D is it consists of the 150 amino acids. That is false, because it consists of 191 amino acids, and it is mainly the catabolic in action. No, it is false. It is basically involved in the growth hormone, and it has anabolic effects. Now again, they have asked regarding the growth hormone, and these we have discussed that growth hormone is secreted by the somatotrophs of the anterior pituitary gland, and it is released, is stimulated and inhibited by the hormones produced by the hypothalamus, and growth hormone releasing hormone and somatostatin respectively, because somatostatins are inhibitors. The actions of the growth hormone is principally one of the anabolism, and this is reflected in its role of the lipolysis and anti-insulin insulinic properties. And growth hormone is secreted in the high levels during the puberty, when more frequent pulsatile release occurs, and the growth promotes the actions of the growth hormones. They are mediated by the insulin like growth factor 1. Let's see our option. It is secreted by the anterior pituitary gland. Yes, that is true. It is released in a pulsatile manner every 90 minutes. No, that is false, but it does occurs in the pulsatile manners, and stimulates the protein synthesis, because it is anabolic, so it helps in the protein synthesis, and it stimulates the lipolysis. That, yes, that is again true. And it is released in the lower quantities in the patients with anorexia nervosa. No, that is false, because it is increased in high amounts in not very high amounts, but it does increases in the and has the effect on the anorexia nervosa. Now let's move toward the next question, and we have ended here the true and false. Now we are going to move towards the SBAs, and there is a simple answer for each question. We just have to be answer the single best answer. A 16-year-old girl A 16-year-old girl in a gynecology OPD with the primary amenorrhea and excessive facial hairs. Like, they are the two properties. Property number one, that there is a primary amenorrhea, and second is the excessive facial hair growth. Examination reveals the normal genitalias. Apart from the apparently large clitoris, the differential diagnosis of the congenital adrenal hyperplasia. So what are the differential diagnoses of the congenital adrenal hyperplasia? The CHO, which is also called as a 21 alpha hydroxylase deficiency, it is characterized by which of the following? We all know that there is a hypotension, hyperkalemia, and hyponatremia. So option D will be correct. There will be hypotension, hyperkalemia, and hyponatremia. So how does it happen? That 90% of the patients with the congenital adrenal hyperplasia, they have 21 alpha hydroxylase deficiency. This enzyme, they has a function in both the productions of the glucocorticoid and the mineralocorticoids, and therefore the patients, they may have the salt wasting, that is going to cause the hyponatremia, as well as the hypotension. And a deficiency in the mineralocorticoid, they lead to the hypotension as a result of the hypovolemia and hyponatremia, and in case of the hyponatremia, there will be the hyperkalemia. And this is the steroidogenesis pathway. Here you see that this is 21 hydroxylase, and this 21 hydroxylase, that if we see the steroidogenesis pathway, that all the steroid hormones are going to be produced from the cholesterol, and cholesterol, it is going to convert into the pregnenolone, and to 17 hydroxy pregnenolone, and to DHEA. After the actions of the 3 beta hydroxysteroid hydrogenases, and when the progesterone is produced after the action of this enzyme, uh, after that the 21 alpha hydroxylase enzyme is going to act on the progesterone. It converts the progesterone into deoxycorticosteroids and the 11 deoxycorticosols, and then 11 beta hydroxylase acts on to form it corticosterone, and then 18 hydroxycortisone, and then aldosterone. What happened that when there is a deficiency of the 21 hydroxylase alpha hydroxylase, there will be the no production of the aldosterones, cortisols, and the estradiol, in short. Not estradiol, sorry, estradiol is not considered, but the cortisol and aldosterone. And when there is no cortisol and aldosterone, the patients, they have the deficiency, because this is going to act on both the pathways of the glucocorticoids and mineralocorticoids. When they are this is affecting the mineralocorticoids, and there will be decrease of hyponatremia. That hyponatremia leads to the hypovolemia, and hypovolemia leads to the hypotension, and as well as the hyperkalemia. But in the 10% of the cases, there is also the deficiency of the patients having the 11 beta hydroxylase. In this instance, this remains the deficiency of the glucocorticoid. However, there is an accumulation of the deoxycortisols, which may cause the hypertension because of the accumulation of the deoxycortisol, and it can cause the hypertension due to its glucocorticoid properties. So the option D is correct, that there will be hypotension, hyperkalemia, and hyponatremia. Now let's move towards the next question. A 27-year-old woman is seen in the antenatal clinic. She suffered from the hyperemesis gravidarum in the first trimester, and routine TFTs, or the thyroid function test, they have revealed abnormalities. Which of the following is recognize the changes in the regular thyroid functions in the pregnancy? We have discussed previously that there will be the reduced plasma iodine, because there is increased thyroid uptake of the plasma in the early pregnancy. During the first trimester, The increased renal blood flow and the glomerular filtration lead to the increased level of the iodine clearance from the plasma, and patients with the already low levels of the iodine, they are predisposed to the developing the goiter. In the first trimester, the rising levels of the human chorionic gonadotropin to lead to the reductions in the serum levels of the thyroid stimulating hormone, and as it is has a thyrotrophic properties. Because of the structural similarity to the HCG and TSH, pregnancy is associated with increased thyroid binding globulin because of the increased liver production with the subsequent elevated levels of the T4 and T3. So the option E will be correct. There is the reduced plasma iodine concentration in early pregnancy. Now next question. During her pregnancy, a 30-year-old woman is diagnosed with the gestational diabetes requiring the insulin treatment at 28 weeks of the gestation. Which of the following statement they best describe the functions of the human placental lactogen? The human placental lactogen, it has one of the peptides made by the placenta, the human, or also known as HPL enzyme. Its structure and functional similarity it has with the growth hormone, and it affects the maternal metabolism to provide the increased nutrition supply to the fetus. HPL decreases the maternal insulin sensitivity and therefore lead to the great amount of the glucose in the blood. Lipolysis is induced when which lead to the fatty acid being released into the bloodstream. HPL decreases the maternal glucose utilization. HPL is only present in the pregnancy and reaches its highest concentration by the third trimester. It has previously been used as an indicator for the fetal well-being. So let's move to our options. Option A is it enhances the amino acid transfer across the placenta. Yes, that is true, and it has insulin like properties. Um, no, no. It increases the glucose utilization. No. It increases the insulin sensitivity in pregnancy. No. And it is a growth hormone antagonist. No. So option A is correct. Question number 37. A 34-year-old is admitted to the labor ward at 31-week gestation with the threatened preterm labor. She is given 2 doses of the steroid as the precautions. Which of the following describe the first step in the synthesis of the steroids? We have discussed previously here in this diagram that the first step of the steroid genesis is that the cholesterol is converted to pregnenolone under the enzyme 3b hydroxy steroid dehydrogenase are converted to the progesterones. So the option E will be correct, that there is a conversion of the cholesterol to the pregnenolone. Conversion of the corticosteroid to the node, that is not the first step. The first step is the conversion of the cholesterol to the pregnenolone. Now let's move towards the next question. The question, which of the following is an action of the cortisol? Like how cortisol they are going to act. The cortisols, the actions of the cortisol, they are summarized that they are going to increase the plasma glucose levels because there is increased gluconeogenesis and increased glycogenesis and increased glycogen storage. These are all going to produce the increased glucose, increased plasma glucose, and then there is increased lipolysis, which also lead to the production of the glucose and the fatty acids, and the increased protein catabolism, and then there is the sodium and water retention, and then anti-inflammatory and increase the gastric acid production. Hence, the action of the cortisol's increase is the decrease glucogenesis. It is decrease glucogenesis because it helps analgesia no have no effect with the analgesia. Decrease catabolism of the protein, no, they do increase the catabolism of protein, and decrease the gastric, no, they do increase the production of the gastric acid, and then increase the gluconeogenesis. Yes, that is true. The option is true. The option is correct. Okay, here the option E is correct, not the decreased gluconeogenesis because they are going to increase the glucogenesis. Now let's move towards the next question. A 28-year-old female is referred to a gynecological clinic with the primary infertility, and on examination she has a round face, prominent stretch marks on her abdomen, and a hirsutism. Which of the following is not a feature of the Cushing syndrome? So the Cushing syndrome, here the answer is diabetes insipidus, because Cushing syndrome, it is a state of excess cortisol. The characteristic features, they includes the truncal obesity, a red puffy and round face, and hypertension, depression, osteoporosis, diabetes mellitus, and hirsutism and amenorrhea. The causes of excess cortisol productions, they fall into four major categories. They are the iatrogenic, yes, it can be done iatrogenically, and excess adrenocorticotropic hormone production by the primary tumor, which is known as the Cushing disease, and also the adrenal cortical neoplasm producing the steroids, and the ectopic production of the ACTH by the non-pituitary tumors, like for example the lung tumors. So here the option A will be correct, that diabetes insipidus has no role with the Cushing syndrome. And next question, a 26-year-old female is referred to a gynecological clinic with the abdominal pain and amenorrhea. You suspect that she is having a Cushing syndrome and decided to send her for the test. Which of the following tests would be suitable for the confirmation of the diagnosis? So for the confirmation of the diagnosis, the test is the low dose dexamethasone suppression test. The low dose dexamethasone suppression test. The best screening test is the overnight dexamethasone suppression test, which is used to eliminate all those with no abnormalities. The false positive is to be seen in the alcoholics, and those with the anorexia nervosa, and anyone taking enzyme inducer medicines. In this test, if this test is positive, then further tests are done to localize the disease. Low dose dexamethasone suppression test involves the giving the 0.5 mg per 6 hours only for 48 hours, and then measuring the plasma cortisols at the 0 hour and 48 hours. This test is used to confirm the diagnosis, and the localization of the disease is done by the high dose dexamethasone test, and complete or the partial suppression indicates the Cushing disease, and testing plasma adrenocorticotropic hormones. So the answer will be the low dose dexamethasone suppression test, and high dexamethasone suppression test is used to localize the disease. Okay, now next question. The 52-year-old woman with the Cushing syndrome is referred to the pre-assessment clinic prior to the vaginal hysterectomy. Which of the following is a feature of the Cushing syndrome? Is a feature of the Cushing: decreased plasma lactate dehydrogenase, no, there is an increase, and the hypoglycemia, no, there is the hyperglycemia. Hypokalemia, yes, hypokalemia, because in raised levels of the in the Cushing syndrome, there is a decreased level of the potassium. So the option will be the hypokalemia. The Cushing syndrome, it is a disorder of the high serum cortisol, which has many causes and has been discussed in our previous SBAs, and the most common cause is the exogenous administration of the steroid hormone. Cushing syndrome refers to the Cushing syndrome disease caused specifically by a tumor of the pituitary gland, which secretes large amounts of the adrenocorticotropic hormone, leading to the high cortisol levels. Patients, they may have the hyperglycemia and insulin resistance, and causing the diabetes mellitus, and all of the following are the potential features of the Cushing syndrome except for the hyponatremia. Finding of the hyperglycemia and hypokalemia, they may be accompanied by the hyponatremia as a result of the increased aldosterone levels. So the hypokalemia is the answer. Now let's move to our next question. That is, a 18-year-old woman is seen in the gynecological clinic for the investigations of the amenorrhea. You notice that she is overweight with the hirsutism, a round face, and acne. Although the looking up recent blood test, you notice that her plasma cortisol is high and her adrenocorticotropin hormone is undetectable. What is the most likely diagnosis, most likely cause of these results? It is the Cushing syndrome, because the Cushing syndrome, it results of the adrenal tumor. They leads to the increased plasma cortisol at a very low level of the ACTH. So these are the laboratory in lab investigations that the levels of the cortisols and adrenocorticotropin hormones in the pathologies. Like if the patient has a cortisol problem and if she has ACTH, how you are going to differentiate the low to midnight levels are normally the cortisol is are normal in the low to midnight, and they are high at the 8 a.m. ACTH, they are not raised, and in the primary adrenal failure they are the low cortisol levels but the high ACTH. In the steroid therapy, the cortisol levels are varied, and ACTH levels are also varied. In the Cushing or the adrenal origin, they have the high cortisol levels, and the ACTH, they are undetectable. In the Cushing or pituitary origin, they have the high cortisol levels and they have the high ACTH. In the Cushing ectopic ACTH production, the cortisol levels are high and ACTH are very high. Now, next question: what is the site of the action of the antidiuretic hormone? We know that the antidiuretic hormone or vasopressin, it is a peptide hormone, and it helps to regulate the water hemostasis, and they act on the collecting duct. The option B is correct, and it is released from the posterior pituitary in response to the increased osmolarity of the plasma, and they acts on the distal tubes of the kidney to increase the water absorption via the insertions of the aquaporins and the water channels into the membrane. By increasing the water reabsorption of the kidney, the osmolarity of the urine is increased, and the nephrogenic diabetes insipidus is caused when the kidney becomes unresponsive to do ADH. Acquired forms of the nephrogenic diabetes insipidus, they may be triggered by the hypokalemia, pregnancy, and hydronephrosis, or the drugs lithium. Now let's do our next question. It is a 72-year-old woman is seen in the pre-assessment clinic prior to the undergoing a routine channel hysterectomy for the prolapse. Her blood pressure is found to be high and electrolytes are deranged. Which of the following is secondary cause of the hyperaldosteronism? It is the renal artery stenosis. We all know that, because the primary hyperaldosteronism, it is an excess production of the aldosterons, and independent of the renin-angiotensin-aldosterone system, and the features suggestive of the hyperaldosteronism, they includes the hypertension with the hypokalemia and alkalosis. The greater than 50% of the cases, they are due to the Cone syndrome, a unilateral adrenocorticoid adenoma. The most appropriate form of the treatment in this case is the laparoscopic removal of the tumor, and other causes of the primary hyperaldosteronism includes the bilateral adrenal hyperplasia, and spironolactone therapy is often successful in treating the cases. The secondary causes of the hyperaldosteronism includes the renal artery stenosis, which leads to the perceived hypoperfusion of the kidney and increased secretions of the renin and aldosterone. The hypertension is often refractory to the treatment, and especially with the angiotensin converting enzyme inhibitors. And the syndromes of the inappropriate antidiuretic hormone, these secretions, they have multiple causes, including the small cell carcinoma of the lung, stroke, and the encephalitis, and the postoperatively. Excess secretions of the ADH, they leads to the hyponatremia and the fluid overload. Now let's move to our next question. A 60-year-old woman with a chronic disease is admitted to the hospital acutely unwell. She has severe diarrhea and vomiting. She is hypotensive with the blood pressure of the 85 by 45 millimeter of the mercury. You suspect that she has Addison's disease. Which of the following is a recognized cause of the Addison's disease? It is HIV, and the Addison disease is caused by the primary adrenocorticoid insufficiency, most commonly with an autoimmune cause. It has an incidence of 1 in 100,000 and is therefore relatively rare. Autoimmune, they may lead to the antibodies against the against the adrenal glands, and may be associated with the other autoimmune disease, including the thyroid disease, pernicious anemia, and diabetes. Other causes include the tuberculosis and acute bleeding into the adrenal gland, the Waterhouse-Friderichsen syndrome. HIV is now a common cause of Addison disease in areas where the HIV is prevalent. Sarcoidosis is not classically known to cause the Addison's disease. Now, next question, and it is a 24-year-old woman is admitted with the vomiting and diarrhea at 26 weeks gestation. Her electrolytes are deranged and fail to resolve after the acute event, and she requires admission in the high dependency unit. Addison's disease is suspected. Which of the following is most appropriate and initial specific test for the Addison disease? The initial test is the short ACTH stimulation test. And why it is so? That the Addison disease, it does not become the apparent until the 90% of the glands is destroyed. Hyperkalemia and hyponatremia, they are the usual initial laboratory findings with the symptoms of the fatigue, abdominal pain, weakness, constipation, and hyperpigmentations, and the weight loss. In severe cases of the Addison's crisis, there may be the postural hypotension confusion. Diagnosis is usually confirmed with a short adrenocorticotrophin hormone stimulation test, and when the plasma cortisol levels, they are tested before and after the synthetic ATCH, the long ATCH stimulation test, they may be used once the results of the initial short test are noticed to be abnormal. In treating Addison's disease, it is essentially to replace the glucocorticoids or the hydrocortisones and the mineralocorticoids or the fluorocortisones. The hyperpigmentation is caused by the excess of the ACTH, which is released by the pituitary in order to trigger the productions of the cortisols by the adrenal gland. In the secondary adrenal failure, there is low ACTH due to the deficient corticotrophin releasing hormone, and which is released by the hypothalamus. Let's move to the next question. Which is the first catecholamine to be produced in the synthesis of the catecholamines? Options are dopamine, epinephrine, non-epinephrine, phenyl alanine, and tyrosine. The option correct is the dopamine. Why dopamine? Because catecholamines are derived from the amino acids, the tyrosine, and they have a half-life in the circulation for a few minutes. And the first step in the conversion of the tyrosine to L-dopa by the enzyme tyrosine hydroxylase, and this reaction which forms the rate limiting steps in the synthetic pathway. Dopamine is the first catecholamine to be produced, and followed by the non-epinephrine and then epinephrine. Catecholamines, they are degraded by the catechol O methyl transferase, which is also known as COMT, or the monoamine oxidase, or also known as MAO. Now the next question: a 48-year-old woman is found to have the persistent hypertension during a woke-up for a gynecological operation. Further investigations reveals a pheochromocytoma. Which of the following biochemical changes is associated with the pheochromocytoma? Basophilia, no. Hyperglycemia, yes, that is true. Hyperkalemia, no. And hypercalcemia, no. And reduce the urine catecholamines, no. The pheochromocytoma, it is a tumor that produces the catecholamines and is a rare cause of the resistant hypertension. It is usually found in the adrenal medulla, and however 10% are found elsewhere. Other symptoms includes palpitations and psychological symptoms. Investigations, they may reveal the glycosuria in up to 1/3 of the patient. Hyperglycemia is caused primarily by the stimulation of the lipolysis because of the catecholamine production. Stimulations at the adrenogenic and receptors, they lead to the glycogenolysis and gluconeogenesis. 30% of the patients, they have the glycosuria during the attacks. Investigations to establish a diagnosis of the pheochromocytoma includes a 24-hour urine collection for the vinyl mandelic acid, which is catecholamine metabolite. Hyperkalemia and the basophilia are not typically associated with the pheochromocytoma. Now question number 49, that which of the following action is related to the glucagon? The decreased gluconeogenesis, no. Glucagon. The decreased ketone body production, no. The decreased plasma glucose, no. Increased glycogenolysis, yes, that is true. And reduced lipolysis, no, that is not correct option. And increased glyconeogenesis. Glucagon is a polypeptide composed of the 21 amino acid. It is synthesized by the cells of the pancreas, and it's essential in the control of the glucose hemostasis. Secretion is stimulated by the low glucose states and is inhibited if the blood sugars are raised. In states of the low blood glucose, there is an increase in the activity of the sympathetic nervous system, which causes an increase in the circulating adrenaline. This is in turn stimulates the beta adrenoreceptors and lead to an increase in the glucagon. The main actions of the glycogen is to increase the blood glucose and lead to the breakdown in the stored fat and the proteins, and it acts mainly on the liver. Now, the next question, a 32-year-old Asian woman is diagnosed at the 28 weeks gestation with the gestational diabetes. Treatment with the metformin is commenced. Which of the following is an insulin antagonist? Insulin antagonist. Cortisol, no. The free fatty acids, no. Growth hormone, no. Prolactin, no. Yes, the answer is the somatostatin, because insulin is a peptide hormone which is synthesized and secreted by the beta cells of the islets of Langerhans of the pancreas. It is secreted. It is secreted as a pro hormone, which gets converted to an activated hormone by the proteolytic cleavage of the C peptide. Insulin is the main hormone controlling the blood glucose levels. Insulin is released in response to the increasing amino acids, free fatty acids, and the gastric hormone, which are the released in the response to eating, and including the cholecystokinin, gastrin, and the secretin. Insulin release is inhibited by the adrenaline and the somatostatin. Now, question number 51. A 51-year-old woman is started on the hormonal replacement therapy. You consider the properties of the estrogen. When discussing the contraindications to the HRT treatment, which of the following is the property of estrogen? Decrease bone formation, no. Decrease circulation coagulation factor, no. And increase the bowel mobility, no. Reduce the triglycerides in the blood, no. It stimulates the growth of the endometrium. Yes, that is the true answer, because estrogen, they has the effects on the on the coagulation, because coagulation. Increase circulating coagulating factors, including the plasminogen factor 2, 7, 9, and 10, increases the antithrombin 3. They act on the lipids to increase the higher density lipids and increase the triglycerides and reduce the low density lipoproteins. They have effects on the intestinal, as it reduces the bowel mobility, and they have the structural effects that they stimulate the endometrial growth, and they increases the discharge and lubrication. They increase the bone formation. They promote the formation of the secondary sexual characteristics, and they have the acts on the fluid balance, increases the salt and the water retention. Now let's move to the next question. A 21-year-old woman is treated on the mini pill. She asked you about the possible side effects of the progesterone. Okay, the side effects of the progesterone: increases the contractility of the uterine smooth muscle cells, no. Increase the respiratory drive. Yes, that is the answer, because the progesterone, it is the C21 steroid hormone which is derived from the cholesterol, as well as increasing the respiratory drive. It reduces the bowel mobility and increase the basal body temperature. Level increases during the luteal phase of the menstrual cycle in the preparation for the fertilization of the ovum. If the pregnancy does not occur, the corpus luteum, they degenerates, and the levels of the progesterone fall. Progesterone, they protect the endometrium from the cancer. Question number 53. A 32-year-old woman is referred to the gynecology clinic with the secondary amenorrhea. Day 21 progesterone levels, they indicate that she is not ovulating. Which of the following statement they best describe the events occurring at the mid-luteal phase of the menstrual cycle? And the option is that estradiol decreases and FSH increases in the mid-luteal phase, because during each menstrual cycle up to the 10 secondary follicles they are recruited, of which the one will become the dominant follicle and the rest regresses. This is the pulsatile production of the gonadotropin releasing hormone from the hypothalamus and subsequent release of the follicle stimulating hormone and luteinizing hormones from the pregnancy. Pituitary, the developing follicle, they produces estrogen under the influence of the FSH, and LH, they acts on the thecal cells of the ovary to produce the androgens, and there is a feedback from the ovaries production ovaries hormones to the pituitary and the hypothalamus. The follicle stimulating hormone of the ovary to produce the estrogen, which stimulates production of the glandular endothelium. As the estrogen the levels increases, that 14 days before the onset of the menstruation, becomes high enough to trigger a surge of the LH, which in turn stimulates the ovulation. Once egg has been released, the corpus luteum, they causes increased production of the progesterone and the subsequent proliferation of the endometrium. If fertilization they does not occur, the hormone levels they falls as a result of the failing corpus luteum, and there is the onset of the menstruation. A 34-year-old woman, they undergo the regular ultrasound scans for the follicle tracking, and they have been started on the clomiphene treatment. Which of the following statement they most appropriately describe the mature ovarian follicle? It is that it is surrounded by the thicker cells. A layer of the thicker cells surrounds the mature follicle once it has reached the secondary stage with the two layers of the granulosa cells. Both of these layers of the cells serves to protect the developing follicle, and during the development, and oocyte they will grow up to the 120 micrometer in diameter, and development is controlled primarily by the follicle stimulating hormone rather than the luteinizing hormone, and it does not produce the progesterone. Let's continue with our question number 55. A 23-year-old woman is seen in the gynecological clinic for an ultrasound scan reveals the multiple cysts on both ovaries. She also complains of irregular menstrual cycles and have been trying to conceive for over 1 year. Which of the following they lead to the clinical manifestation of polycystic ovarian syndrome? Decrease in the estradiol level, no. Decrease in the prolactin, no. Decrease in the testosterone and aldosterone, and increase in the fasting insulin, yes. There is the increase in the fasting insulin is the option, because polycystic ovarian syndrome, it is the most common endocrine disturbance affecting the woman, and it can be familial. Signs and symptoms, they vary amongst women, and they even in the individual over the time. The clinical symptoms ranges from the obesity to the menstrual irregularities and to fertility, hirsutism, and acne, and elevation in the insulin, and they are the common in both the thin and obese patients with the PCOS, and it is thought to that the insulin stimulates the androgens secretion, and this appears to be an insulin resistance in those women who then have an increased risk of the developing diabetes. Last question, and this is which of the following increases the sex hormone binding globulin, and it is hyperprolactinemia. The sex hormone, the binding globulin, is synthesized in the liver. 80% of the testosterone is bound to the sex hormone binding globulin, and 19% to the albumin, and 1% is unbound. Biological effects of the circulating androgen, they depends primarily on the unbound fractions, and its production is increased by the androgens and insulin. On the other hand, the estrogen increases the production of the SHBG, and hence the hirsutism is improved by taking the oral contraceptive pill and during the pregnancy. So this concludes our chapter of the endocrinology, and in the next video we will do the statistics and epidemiology, and hope you like the video. If you like the video, like, subscribe, share, and till next video, take care. Bye bye.